We're going to post pharmacology because it's Sunday and I don't go live on Sundays normally. So we're just going to post the video for y'all. We're going to run through pharmacology foundations right quick, which is definitely important, just so y'all know. So make sure that everybody is aware. Hang on a minute. Gotta make sure we shared that out. So, all right, guys. So we got the 5 rights of medication, 3 plus the 3 checks: high alert meds, look-alike, sound-alike drugs, cardiac meds, respiratory, neurological, endocrine, and insulin. The antidote master table, drug toxicity recognition, and the Nclex pharmacology strategies. Healing hearts, leading with love, and changing lives. Compassion in my heart and excellence in my care. Faith in every step. That's my motto. And no nurse left behind. So this is safe medication administration, y'all. So we got the 5 rights. Right patient. You need 2 identifiers, the name plus the date of birth or the MRN. You never use a room number. Why? Because room numbers change like we change our draws. All right. Nclex tip. Verify before every dose, even if you know the patient. 2, right medication, generic versus brand names. Know both. Furosemide equals Lasix. Metoprolol equals low pressor. Check. 4, look-alike, sound like names before drawing up the medication. 3, the right dose. Check the order versus the label versus the drug reference. Weight-based dosing. Milligrams per kilograms for peds. That's very important, y'all. For the Nclex tip, double check high alert drugs with a second nurse. Right route, PO, IV, IM, sub-Q, sublingual, topical, inhaled. Can you be quiet? Each has a specific technique, guys. So if y'all know, we can give PO low pressor or metoprolol, right? We can give that medication by mouth. And if we got somebody that's having SVT and we need to fix it right away, we ain't got time to wait for it to go through the gut, okay? We need to make sure that we get that done quickly. So in turn, we're going to give it IV. So a person may have an order for metoprolol PO, or they may also have an order for metoprolol IV. I'm sure that you know what an indication is, and an indication is a part of that order. If you do not give the medication for the appropriate indication, you are not following a physician's order and you are acting outside of your scope. All right? Just so you know, scope is important. Okay? You can get through there. Oh, go ahead. Okay? The right time, check the frequency and timing. AC is before meals. PC after. PRN is as needed. Oh, back to the right route. Nclex tip. Never crush enteric coating or extended release. XR, ER, SR tablets. Never crush them. There's a reason why they have that coating on them. The right time. Check the frequency and timing. AC, I just told you that. Nclex tip. QD and QID. Look-alike abbreviation error. Write out daily and 4 times daily. Okay? The 5 rights plus the 3 checks and the 6th right. 3 checks when removing from storage. That's 1. Number 2, before preparing. And 3 is before administering. The 6th right is the right documentation. Chart immediately after giving, never before. That's an Nclex rule, okay? Another Nclex rule is the first action before any medication is always to verify the 5 rights. When in doubt about a medication, stop, look it up, call pharmacy. This is always safe. Remember that Nclex is a safety exam. Medication error, first action, assess the patient, then notify the provider, and then document. Okay? This is the Nclex danger drugs. Insulin, hypoglycemia risk. Wrong type or dose can be fatal. Insulin can kill the patient. I'm going to say it again. Insulin can kill the patient. Okay? All right. Check the blood sugar before every dose. 2 nurses verify. Okay? I know that every policy is different, but per the Nclex, it's a high-risk drug. 2 nurses verification. The antidote for insulin is D50. D50 IV for a conscious patient, or glucagon IM for unconscious. Okay? I said D50 IV. We give D50, we push it IV whether they're unconscious or not. If they're conscious, you can give them some type of sugary substance. We talked about heparin the other day. We got IV versus sub-Q. Okay? You got what? Why is it a high alert? Bleeding risk. Narrow the therapeutic range at APTT is 60 to 100 seconds. Okay? I did create this Nclex specific, guys, so that it will help you. All right? I'm not looking at the screen, so whomever is on there, welcome in. All right? I'm recording this so that we can post it. So, for the heparin, monitor the APTT, check for bruising, hematuria, or black stools. Why are we going to check for hematuria and black stools? Because if they're having some blood in their urine or their stool that was not happening before we put them on heparin, it is likely that they're having adverse bleeding. Okay? What is the antidote? We talked about it the other day. Protamine sulfate is for heparin and Coumadin is vitamin K. Okay? Coumadin is our next high-risk drug. Narrow the therapeutic index. 0.5 to 2.0 is the normal. Toxicity is common with Coumadin, guys. You need to check. I'm sorry, I'm on the wrong one. I'm tripping. Bleeding risk, many drugs, and food interactions. You need to monitor the INR because people can get outside of their therapeutic range, and it is common for them to have toxicity. Avoid vitamin K rich foods. We talked about that the other day, like collard greens, like spinach, okay, leafy green. Vitamin K is the antidote. Digoxin or a Lanoxin, okay? What?
Hot.
What's hot?
Okay.
I'm gonna whoop your tail. Digoxin or Lanoxin, guys. Dig toxicity, right? We got dig toxicity. All right. Why is it a high alert? Because it has a narrow therapeutic index. I already read this once. I was just ahead of myself. 0.5 to 2.0 is the normal dig level. Toxicity is common, very common. You want to check the apical pulse for 1 full minute. This is the critical nursing action. Hold it if it's less than 60 and monitor their potassium. All right. Digoxin, Digoxin immune fab. That Digibind is the antidote. Opiates. We got morphine, fentanyl, and oxy. Respiratory depression, sedation, and falls risk is why it's a high alert. All right. The critical nursing action. Monitor the respiratory rate. Hold if it's less than 12. Have naloxone at the bedside. The antidote is Narcan, aka naloxone. Then we have another drug class, concentrated electrolytes, like sodium chloride, 3% sodium chloride, or potassium chloride. When people get the chamber, they're getting potassium. Potassium will stop your heart. Okay? Why is it high risk? Cardiac arrest if given undiluted IV push. You never, ever give potassium chloride IV push unless you're working in a prison setting and it's ordered to do so. It must be diluted and infused on a pump. It must be diluted and infused on a pump. Potassium chloride intravenously must be diluted and infused on a pump. I said it 3 times. It's going to be on your Nclex. Okay? Antidote, calcium gluconate for hyperkalemia. Calcium gluconate is the antidote for hyperkalemia. You will need to know what the antidote for hyperkalemia is for your Nclex. Okay? Benzodiazepines. Remember we talked about drug classes and stuff. These are your PAMs, right? Your PAMs. The benzodiazepines. Lorazepam, diazepam. All right? This is your Ativan, your Valium, your Xanax, those things. Your temazepam, okay? Respiratory depression, fall risk, and dependence. Benzos have a very high risk for dependence, guys. A very, very high risk for dependence. Okay? And they also are known in a CWA protocol. Also for what? Alcohol withdrawal syndrome. Opiates will make you feel like you're going to die, but benzodiazepines and alcohol can cause you to go into cardiac arrest and you can die from going through withdrawal. You can also have seizures if you're withdrawing from benzos and alcohol. All right? Monitor sedation, fall precautions, and do not stop abruptly. You do not stop abruptly because of what I just told you. It can cause seizures. It can also cause cardiac arrest. Okay? Do not stop benzos abruptly. That's why when people come into the hospital or wherever you may be working, if it's an inpatient, Montana, be quiet. If it's an inpatient treatment facility or something to that nature, okay, Mom, get some chips. That's why they, okay, that's why they taper people down. That's why we often give Ativan when we are treating people for alcohol withdrawal. Why? Because it is a pill form of alcohol. It has the same physiological effect on the body as alcohol. We do not want to send people into a withdrawal that we cannot control or that can cause seizures or death. Okay? We want to make sure that we are safely detoxing people. That's why sometimes you will have people that go to an inpatient treatment facility and they are then sent to the hospital to do the medical part of the detox to ensure their safety. And then once they've been sober for a certain amount of days, then they come back to the inpatient treatment facility. Okay? All right. Another high profile drug I bet you did not know is Tylenol. And you know why? Because people fail to realize that it's a high risk drug and they overuse Tylenol. It causes hepatotoxicity at more than 4 grams per day or 2 grams per day with liver disease. Okay? Check all the combination products such as hydrocodone, oxycodone. Those drugs have Tylenol in them. You may have a 5-3-25, which means 5 milligrams of oxy or Norco, and the 325 or the 500 is your additional Tylenol. You need to ensure that you are taking all accounts of Tylenol into consideration when you're giving these drugs. So if I give somebody 2 oxycodone with 500 milligrams of Tylenol, so a 500, all right, that's going to be 10 milligrams of oxycodone and 1,000 milligrams of Tylenol. Do you think I should give their per diem Tylenol with that oxycodone? If you do, you need to do some research. The answer is no. Okay? You need to wait a couple of hours. Some people do have pain that is uncontrolled, and we do need to make sure that we're giving them thorough pain relief in between, in between they have breakthrough pain. So we may give them Tylenol or we may give them ibuprofen or whatever it may be. You need to be cognitively aware of how much Tylenol the person has taken in. All right? You check all the combinations, and what is the antidote is Mucomist. That crap is yucky. High alert drug Nclex rules. You need to know these. You should memorize these and you should be aware of these. Digoxin. You check the pulse plus the potassium every time. Hypokalemia potentiates toxicity, and it is a deadly combo with the drug digoxin, aka Lanoxin. Digoxin plus low potassium, which is also known as hypokalemia, it potentiates for a fatal outcome. It's a deadly combination. With insulin, 2 nurses verify the dose. I don't care what your facility says. When you are taking the Nclex, 2 nurses verify the dose. Always clear before cloudy when mixing. Clear before cloudy. The cloudy has the clear in it, but the clear don't have the cloudy substance in it, if that makes sense. All right? If that's a way you can memorize it, that's how I memorized it. You do not want to mix cloudy with clear. Okay? So clear before cloudy if you mix it in the same syringe. Just so you know, that question will probably be on your Nclex. But in real life, I don't put insulin in the same syringe. I put, if it's R, I put R here. If it's 70-30, I got another syringe. Yes, I know it's sticking the patient more than once, but I'd rather be safe than sorry. Okay? All right. Potassium chloride. You never push it IV. Never push potassium chloride IV unless you're working at the prison. Oopsie, made a poopsie. Potassium chloride, you do not push it IV. This is the number one Nclex lethal medication error question. Number one Nclex lethal med error. Do not push potassium chloride. It has to be diluted and it has to go through a pump. Opiates. Respiratory rate less than 12, you hold the drug. You give Narcan and notify the provider. If you give somebody an opiate and their respiratory suppressed to below 10 or below 12, I'm going to notify the provider before I give them Narcan, because Narcan is going to make them mad in real life. But for test purposes, if it's below 12, you give Narcan and you notify the provider. Some people may already have a suppressed respiratory system. They could be on end-of-life care, palliative, whatever you want to call it, and that might be the expected outcome. Okay? All right, let's moving on. Moving on up to the sky. Coumadin, a.k.a. warfarin. INR. If the INR is greater than 3.5, hold the Coumadin and notify and anticipate vitamin K, because you are likely going to be giving an antidote if their levels are, if their INR is greater than 3.5. Why is that? Well, that means it takes 3.5 seconds for their blood to clot, and that is too darn long. Okay? Sorry, y'all, I'm hungry. Then we got section 3, look-alike, sound-alike drugs. We also call them LASAs, L-A-S-A. Look-alike, sound-alike, L-A-S-A. Hydroxyzine Vistaril. That is a weaker version of Benadryl, pretty much. Hydralazine, also known as apresyline, is a blood pressure medication. They work very differently. Hydroxyzine doesn't really have that much effect on most people in my clinical experience. Hydralazine, on the other hand, will tank your blood pressure in a New York second if you give it to the wrong person and you just give it the wrong way. Huh? I'm done eating tater chips, so I'm sorry. Dopamine and dobutamine. Dopamine and dobutamine. Dopamine is a blood pressure, renal perfusion. Dopamine is a cardiac contractility drug. Okay? Dopamine is a blood pressure, renal perfusion. Dobutamine is a cardiac contractility drug. Tall man, dopamine versus dobutamine. Okay? Morphine, hydromorphone. They're both pain medications. One is morphine and the other one is Dilaudid. Hydromorphone is 5 to 7 times more potent. The dose is much stronger. Dilaudid is 5 to 7 times more potent than morphine. Okay? You want to make sure that you are cognitively aware of what you're giving before you give it. Do I got y'all all up there too high? There we go. Is that better? All right. Clonidine or Klonopin. Clonidine is an antihypertensive. Klonopin is a benzodiazepine. One treats blood pressure, the other one treats anxiety. Both very different. Antihypertensive versus benzodiazepine. Check the indication before you, Tall man. I use tall man. Clonidine versus Klonopin. Okay. Metformin and I never say this right. Flagyl. I don't say it right. I can't say it. One is for diabetes and the other one is an antibiotic. Check the indication before you administer, because if people are allergic and you give an antibiotic, they could have anaphylaxis. That's with any drug, but Flagyl is an antibiotic. So Celebrex versus Celexa. Celebrex is an NSAID. Celexa is an SSRI antidepressant. Read the full generic name. Completely different drug classes. Okay? Tall man lettering, the Joint Commission safety standard. I said tall man. Capital letters highlight the different parts of similar drug names. If you ever wonder why drugs have tall letters in them, it is to identify it's the Joint Commission safety standard to identify the different parts of similar drug names. Hydralazine versus hydroxyzine. Dobutamine versus dopamine. Clonidine versus Klonopin. The Nclex rule: when you see two similar drug names, stop and verify. Safety. The Nclex is a safety test. Okay? All right. Now, this was considered for day 2, but I'm going to keep it rolling because I'm going to give it to you because it's the weekend. Actually, no, we're not. We're going to save that one because we need to talk about. I had this broke down in 3 classes. Yeah, I can do that right quick because it won't take but a minute. All right. So we're going to talk about the top drug classes for the Nclex. Remember, I told you guys you should break them down. I am going to put this in the stand store. I highly suggest you go get it and you look at it and you keep this chart wherever you may be. You need to know these drug classes. You're not going to be able to memorize all the drugs, but you need to memorize the drug classes. We talked about beta blockers. What, baby? Okay. We talked about beta blockers. I'm going to get you a wipe. Will you stop screaming? Wait. We talked about beta blockers. They end in LOL. Now, you may not be able to remember labetalol, metoprolol, carvedilol, all of those drugs. However, you know that they are all called a beta blocker because they end in laughing out loud. LOL. OLOL, I'm sorry. OLOL. OLOL. All of these drugs treat blood pressure, but they are also focused on the heart rate more so. If I have somebody that has a blood pressure that is teeter-tottering the line, but I need to give them metoprolol or labetalol or carvedilol for their heart rate that's 150, I'm likely going to be very, very much selective on whether I hold the drug or not. If it's on the line of safety, I'm going to talk with the doctor and I'm going to let the doctor know my thoughts and concerns, and we're going to talk about. Okay, wait a minute. We're going to talk about the risk versus the benefits. What is a higher risk? If I hold this medication and this patient goes into uncontrolled rhythm, or it flops them into AFib or whatever it may be, I'm going to talk to the doctor. I'm not just going to hold this medication without notifying, nor should you hold any medication without notifying the doctor. What? Okay, eat your chips and you can go upstairs. Okay? Metoprolol, atenolol, carvedilol. I forgot about atenolol, my bad. The action for your beta blockers lowers the heart rate, lowers the blood pressure. The myocardial O2 demand. It also decreases the oxygen demand. Your key nursing considerations: monitor heart rate and blood pressure. Do not stop abruptly. You will get rebound hypertension and angina. Do not stop beta blockers abruptly. If you get an admission to the hospital and you see one of their home meds is a beta blocker, you need to say, hey, doc, they're on blah, blah, blah at home. Are we really going to discontinue this? If we are going to discontinue it, you should chart that you told the doctor and that you cover your behind. I call it CYA. You should learn it. Hello, everybody. Thank you all for coming to class. I'm literally on the other side of the phone. Sorry. I appreciate y'all being here. Guys, these are top drug classes for the Nclex, like we talked about the other day. Some things you need to know. I will upload this. The video will be posted in the LINK in my bio, as well as the class information. Do you guys want me to go ahead and post it right quick so you all can get it? I'm gonna, you guys that are live, I'm gonna pause my video and I'm going